Don't get talked into things you will regret. And I learned this one the hard way early in my career. We want to help people, we want to please people, we want to give people what they want. Do not promise that you're going to be doing, endo post and core crown on an anterior tooth on a person with a profound or severe intellectual disability and resistive behaviors in the operating room. It's not something that should be done, okay? This means the consent must be open-ended. This is a difficult discussion with family. When the consent should say something like, all necessary treatment, which could include extraction of some teeth, including front teeth, or extraction of all teeth. Because it is not all that unusual, keeping in mind that patients with intellectual disabilities also have a higher prevalence of seizure disorders, self-injurious behavior. It's not impossible that you're going to take a patient in for some identified problem with their posterior teeth, and you're going to find that there's some massive radiolucency associated with one or more of their anterior teeth because of trauma or whatever. So the family and the patient have to be prepared that we know we're doing at least this. This is the minimum that we're doing. And the picture when we get a good clinical exam and radiographs might be much worse. So you might end up having much more treatment than you bargained for. And you have to be comfortable with this, because I can't take a person to the operating room, have the anesthesiologist put them under anesthesia, identify serious problems, and leave those problems alone. That's not an option. That is not in the patient's best interest. That would be the wrong thing to do. So everybody must be at least potentially willing, or they must be willing to have the patient lose teeth that you might not think they need to lose, depending on the clinical exam and the x-rays. Do not bargain, do not negotiate, and the hardest part of this is do not take it personally. But certainly you can save the front teeth, and certainly you can understand why I don't want my daughter to be missing any front teeth. Well, of course I understand that. This is not the ideal situation. This is just the best that we can do for your daughter. And if it were my daughter, go back to the golden rule. If it were my daughter, I would take her in for anesthesia, or I wouldn't do it, I'd have someone else do it. And if they told me that there were reasons to extract the front teeth, if they find them, I would allow it, because I think that's in the best interest of the patient. If the family and the caregivers do not buy this, you can't take them to the operating room, because you're asking for trouble. You cannot identify pathology and then leave it, because that's going to come back to have a negative effect on the person. And you can't treat without consent or without understanding, because that's going to have a negative effect on everybody involved, including you. So you cannot negotiate these things. Here is my hierarchy of concern, and I try to put this in terms that the family and the caregivers can understand, and if you do this correctly, most people are reasonable. The most important thing is the safety of your person. The next thing is the health of the person, and then the comfort, then the function, and then the aesthetic concerns of the person. And then, if all of those things are met, the aesthetic concerns of the family and caregivers. Okay, yes, we understand you want us to have your person end up with the nicest smile that they can end up with. That is an important thing, but it is not as important as the safety, the health, the comfort, or the function of your person. We have to be a little bit realistic, and we all have to be on the same page, or it doesn't happen. And I say don't take it personally, because we do take things personally. We want to help people. And it's very hard to say, I'm sorry, I cannot take your person to the operating room under these circumstances, because I can't provide care or fail to provide care that I think is appropriate and necessary. It doesn't work that way, because if I think it's in the best interest of the patient to do this, and you don't believe me, or you don't trust me, or you're not on board, I shouldn't be treating your person. And it does happen every once in a while. And you're not the only dentist on earth. And my experience has also been that it happens, and then a lot of times the family will come back and say, we thought about it, and okay, we agree. We hope it doesn't happen, but if it happens, we understand that it needs to happen. So I think that's the approach. I don't feel like I fit in, because some people do not take this approach. And certainly what we try to do is provide good function and good aesthetics, but you do what you can do in the best interest of the patient. So invoke the hierarchy of concerns and make it clear that you're acting in the best interest of the patient. This is true in every aspect of dentistry. It's especially true in special care. If the parties involved, meaning the patient, the family, the caregivers, everyone involved, believes that you're acting in the best interest of the patient, they will accept treatment plans. And you need to be acting in the best interest of the patient. The people get defensive sometimes because it's difficult to negotiate the medical system. It's not unusual for a group of people, meaning family, caregivers, and patient, to walk in with a big chip on their shoulder about what should happen or what happened in the past or what's going to happen in the future in terms of dental care. So make it clear that the best interest of the patient is the overriding concern, and you usually are fine. When all else fails, walk away. Punt, okay? You cannot please everyone. So, again, general anesthesia in special care is the treatment of last resort, and the risks of anesthesia must be outweighed by the benefits of treatment, because the risks of anesthesia are fairly high. In a healthy population without developmental disabilities, the risk of death is about 1 in 700,000. It doesn't sound that high, but it's not zero. The risk of serious illness or complication is about 1 in 200,000. And keep in mind that most patients with special needs have multiple comorbidities, so the risk is somewhat higher, although we really don't have good numbers. Let's say it's twice as high. Risk of something untoward happening is probably 1 in 100,000 or something. Is it an acceptable risk? Well, it's an acceptable risk if there is an anticipated benefit that outweighs that risk. If we're just going for a look-see and we're going for a 6-month cleaning, I don't think it is. And I don't think most rational people, if they really look at it that way, would think that the benefit outweighs the risk. Contraindications for general anesthesia, again, pediatric dentistry, healthy cooperative patients who don't need much, yeah, obviously. Any indication that will make general anesthesia a considerable risk for the well-being of the patient. And you will see patients that have situations where they are inappropriate for general anesthesia because of medical concerns. Not very many patients, but some patients. Remember the ASA classification. Okay, those are anesthesia risk classifications. If a patient is a high-risk patient and you don't anticipate a lot of benefit, or even if there is a fair amount of benefit, but they're a very high-risk patient and they're likely to have an untoward event or die for general anesthesia, that's tough. I've only had 1 or 2 patients ever in my career where anesthesia said, we will not subject this person to general anesthesia. The only circumstance under which we would even attempt it is if the choices were the patient is going to die if you don't try it. So those patients are not going to have dentistry under general anesthesia. That's all there is to it, but this is rare. What are some of the complications of general anesthesia? Well, lots of intubated-related injuries, and if you are a resident and then an attending in a hospital, you're going to be called fairly frequently for some sort of tooth damage. Sometimes the anesthesiologists have a difficult time intubating a patient and they crank the tube or they crank the forceps against the anterior teeth and they cause tooth damage. The mandible can be dislocated. You can get tracheal edema from trauma, respiratory obstructions, hypoventilation, aspiration pneumonias, which I talked about a little bit, and I'll again talk about when we talk about what happens in the operating room. Cardiovascular complications, hypotension, hypertension, arrhythmias, neurological complications, awareness. Some people are aware under general anesthesia, and this has got to be horrible, where most people are not, but there are people who hear and see and presumptively even feel everything that's happening when they're under general anesthesia. Some people develop neuropathy, and some people have very difficult recoveries. One thing about general anesthesia in patients with intellectual and developmental disabilities and behaviors is sometimes we need to use medications like ketamine because we cannot start IVs and cannot get the person a level of cooperation. And when ketamine is used, that's used by injection. The emergencies can be terrible because the ketamine can induce hallucinations on emergence. So you've got a patient who has an uncooperative behavior to begin with, who has limited cognitive capacity, who now is hallucinating in an unfamiliar environment, and you can imagine how bad that can be. Positioning, general anesthesia, all of these things, perioperative nausea and vomiting are very common.